Hello, students, and welcome again to our video interviews for Harvard Extension's Innovation Blockchain class. Today, I'd like to welcome our guest, Shada AlSalama. Shada, welcome.
Thank you.
Shada is the Assistant Professor of Information System Security at King Saud University in Saudi Arabia, and she's also a visiting Assistant Professor at the Media Lab at MIT. So, Shada, thank you so much for spending time with us today.
Actually, it's a pleasure. Thank you very much, Mike, for for the invitation. It's a great pleasure to be here. Thank you.
So, students, Shada is going to share her insights on some use cases with a presentation. So, Shada, if you would like to take over and just start with your presentation, I'll just watch and learn.
Thank you very much. Yes. Okay. So I'm very excited about presenting, the work I've been doing over the last, let's say, 6 months, and I'm here to talk about it. So let's start. Today, the umbrella or the aim of the talk is to talk about building healthy blockchain, healthy blockchains of course, in the health space. Now, I'll talk about I'll go through 4 different topics, starting with to set the scene and give you, an overview of exactly where the problem is and how we use blockchains. So this is what I've been doing. Starting with modern healthcare models, I'll just give you a snapshot of how, the current state of modern healthcare and the goals that they want to achieve in that model. I'll also introduce the dilemma caused by that new model and what problems these are causing to legacy systems today. And this is and then I'm going to finalize it with the introduction to blockchain and how I see it in my domain and how it can refurbish those healthcare services using those legacy systems to address that problem. So, modern healthcare models, I'll talk about the snapshot, patient-centered healthcare movement, and eventually the models that I just told you I'm going to talk about. So, let's start with a couple of facts to be considered in the domain. So, today we live in a world, and healthcare is mostly a data-driven domain with 7.6 billion people sharing the world with us. Now, in the next 80 years, expectations are that population will increase to 11.2 billion. Now, this is very good news thanks to the advance in healthcare services. Now, the problem that we see is that this population is actually aging. So what about aging population? Aging population have a very common condition, or let's say circumstance where they have comorbidity. It's very common among aging population or aging old people to have multiple diseases, multiple conditions simultaneously being treated at the same time. Which means that one treatment pathway or following a treatment plan for one condition can actually interact with another condition that they, suffer from. So that's called comorbidity, and comorbidity needs a holistic view. From an informatics point of view or health informatics point of view, that means there is a need for more of sharing information between the doctors that treat those patients, across all the treatment pathways, and they need to consider the whole case or condition and status in order to make and share informed decisions. Now, a lot of governments in the around the globe, they're actually trying to modernize their healthcare systems. Healthcare systems are very slow in terms of, adopting new technologies. That's merely due to the fact that healthcare system actually is treatment and healthcare services is already a burden in terms of collecting the right information, doing so. So adapting new technology will actually need more time, learning time, a learning curve for those doctors to actually adopt those technologies. So that's why sometimes it's just very slow. Now, the modernization approach that most governments are taking today towards a holistic care is actually evolutionary, meaning that they keep what's working and discard what's not working, and build on that and trying to replace systems one by one to help achieve the informatics goals that they want. Let's take one example in the United Kingdom. where they actually how they do their evolutionary approach towards modernizing their healthcare systems. Now, typically, when if any patient or any person actually suffers from alarming symptoms, they just she or he goes to see their family doctor or GP in their clinic, and the general practitioner actually collects information about that patient and ask some questions, check the history, and if they are suspicious, then they would refer that patient to secondary care, which is in the hospital. And the hospital starts with a specialist doing further examination, collecting information from the GP, normally in Britain, and the exact treatment that's actually been implemented. Those information actually faxed to the specialist in the secondary care. And then he collects that information, adds more notes to it, checking more history and doing examination, and then referring that patient to a radiologist in another system within the hospital in order to perform ultrasound and mammogram. And during that, a biopsy is actually undertaken by a pathologist. So each bubble you see here is a different information system, and each color indicates the hospital. So it's the physical premises of the healthcare provider within that treatment scenario. After those three tests, reports are discussed in an initial multidisciplinary care review, which is a room where each one of those people come in that room and discuss each patient's case. Some of them pull their images on the screens. Others print, the results and bring them in. Others bring cards of, case management, and they all shout one name, one patient, and each one having any information about that patient would actually speak up and tell what they have. And then finally, they come up with a treatment plan. 90% of those people, going through that pathway, undergo surgery as the first treatment option. After surgery operation and no notes collected from that, from the surgeon, there is a post-operation MDT with the same people, including the surgeon, in order to discuss if there is a need for any further treatment. And then oncologist normally is this chemotherapy is normally the second treatment option for those people, and normally the plan stops there. If the cancer if the patient relapses years later, then it's really advanced cancer stage, then they normally refer them for palliative care, for end-of-life care. Now, you can see the different colors, and I care about the colors because I care about the systems carrying that information. Each bubble there is collecting information about the patient, and each color indicates the hospital where that system actually exists. So you can see throughout the primary, secondary, and tertiary care how the information is being very discrete and collected in silos. Now, there are multiple discrete information systems. Those systems are not designed to talk to each other. And the new modernization approach towards healthcare is to bring those systems together and have a more patient-centered care, where actually they collaborate, they integrate the services around the patient and his needs. It encourages clinicians to work as a care team and collaborate in order to share informed decisions using these pieces of information that each one of them actually has. That's why it's called shared care. So that's modern healthcare. And the definition of patient-centered care today is a collaborative effort where healthcare professionals and the patient collaborate as a team, share knowledge, and work together in order to achieve one goal, which is optimum healing and recovery. So based on that, today there are a lot of emerging healthcare delivery models, and there are some traditional ones like telemedicine, virtual healthcare. You can see e-health, m-health, u-health. So those are different models to deliver healthcare based on the context and the technology and the infrastructure and the situation of the patient. Regardless of the model that you can see emerging today in the literature, it doesn't matter. They all care about one thing. They all aim to facilitate seamless information sharing for informed decisions, whether it's on, electronically in the healthcare system, or it's an mobile app, it doesn't matter, or through a video conference. So it doesn't matter. They all want to share information in order to make informed decisions. And decisions are exactly why the healthcare services actually exist. What's exactly the best treatment option for that patient? Now, what is the problem? The problem is that this new model is encouraging sharing. So it's allowing, it's asking people or healthcare professionals to share more information than they normally used to do with a traditional approach or model. And at the same time, those healthcare providers and clinicians, there are actually, they have to comply with a thickening web of legislations to protect that information. So they are responsible for the protection and not breaking the law in terms, the HIPAA and all the legislations and laws and acts available there where they have to comply with. So how do they balance between more sharing and at the same time protecting the privacy and confidentiality of that information and making sure that they take good care of it. At the end of the day, whatever the balance they try to attain in their systems, they need to make sure that it doesn't harm the patient. Why? Because more harm is done to the patient if this information is not available to the right person or the right care team whenever needed. Than it falling into the wrong hands. That's the line. That's where they need to actually think of when they try to share and protect in order to make sure that it doesn't harm the patient. Now, those are not my words. Those are actually Dr. Tom Crosby's exact words. And he's the colleague guardian or the chief information security officer at Velindre Cancer Center, where the scenario you've seen actually is being implemented. And he told me that he's actually not an information security officer. So normally in any organization, you would see the person making those decisions is actually an information security officer. In this case, he's actually an oncologist. Why? Because oncologists will be able to understand the information needs in that context better than information security officers who will be just very far, like military, deciding that the information does not go. They don't understand the information access needs. And that's why they appointed a doctor to make those information security decisions. Now, so what is wrong with the current systems to adapt or to reach that balance? We conducted an experiment last year to study the readiness of those systems. So we took the systems, implementing that treatment scenario that I just explained, and there are different systems. And we came with the result. The results show that they actually block information flow. They interrupt the treatment. So they're not really helping with the treatment flow and information flow. And when we investigated even further, we realized that those systems, and you can see here on the screen that there is one doctor and multiple patients. That's the old traditional disease-centered healthcare approach, where actually the doctor doesn't care about other doctors' information, doesn't care about their diseases. They only care about the disease that of their expertise. And that's why those systems to support those clinicians were designed as information silo. They just collect information. They don't care about other systems and connection with them. And when those in this new modern healthcare delivery modernization approach or movement coming, those systems need to actually come together and share the information through the clinicians in order to paint the full picture about that patient. This movement, this change, and this shift is actually resulting in incompatible information security policies where the information needs to be governed. And those policies cannot be actually enforced outside their physical premises, those hospitals. So if they share information with another doctor, they cannot guarantee that this information will be protected. Although by law, the owner of that information, or let's say the originator or the creator of that information is responsible for the protection of that. So because of the law and because of their responsibility, they do not share that information, and that's what's causing the information flow. The block of information flow, and we realize at the end that there is a lack of a unified information security policy to govern that information across patient-centered care beyond their local systems. And this is when I see blockchain coming in handy, because I think blockchain can actually help those systems to cope with that situation and allow for more information flow. And here I'll explain in a couple of slides how I see blockchain technology and my proposal, which is building the healthy blockchain for those systems as one of the use cases for blockchain. And then I have other cases as well. So blockchain, the way I see it from my lens, is that it's a peer-to-peer distributed ledger technology. it's actually not a database solution. So it's not about storing information. It's about having a ledger where you can see, what's happening, painting the full picture, like I say. So it allows for a new generation of transactional applications, and one of them is actually in the healthcare domain. We know that blockchain is mostly used in financial services, but there is a trend in the last 2 years to actually use it in sectors, let's say digital sectors, beyond financial services. And so it is very useful to digitally track asset transaction between a group of participants. In my case, there are the care team caring for that patient, and to provide a tamper-proof trail timestamps of block sequence that can actually establish at the end transparency and trust. So those healthcare professionals will trust each other using that blockchain. It will help build that trust, and they can actually share more information with that trust in place, because the infrastructure allows that. So the aim of my work is to actually use blockchain technology to connect patients, clinicians, healthcare providers, and healthcare information systems and the information to make the right information available to the right person at the right time. And that's the balance, that's the aim, to help those systems. And you can see here just a piece of that information flow that is actually implemented in Britain and other cities, where you can see the different treatment points and the flow of it. That's the workflow of the information being treated. And what I'm trying to do here is, as long as the patient goes down the treatment pathway, regardless of the systems, people, and the information, we need to make sure that blockchain can allow for a seamless cross our systems information flow to each treatment point that you can see in the flow. And as each healthcare professional uses their local systems, transparently a block will actually be generated automatically with a description of that information. So to allow them, to give a snapshot of exactly what information is being collected at which treatment point, by which care team member, and at which hospital. So that fine-grained block is generated and digitally signed by the healthcare professional and added to that sequence. So this will allow, putting that all in coding will help build a smart contract that can have a unified, neutral, conflict-free policy, which is missing in that context, as smart contracts, to govern a fine-grained, patient-centered, comorbid friendly. So we can actually decide, the multiple, and it can give you a view of the different diseases available there and how information connects to paint the full picture, and have a decentralized ledger across those systems to paint the full picture. And you can see here that the full record is virtually generated through that ledger. So you can see for each patient that this blockchain can give a whole view, paint the full picture, and having a description of the full record, and then access is done after that. So they get to know where the information is being going, where the patient's been treated, and they can follow up and see what information is being collected to make that decision. So that's my very first important use case of blockchain use in healthcare space. Now I have other use cases where I think blockchain comes in handy and can actually solve a problem, but not as serious as the one that I just explained. The second use case is about wearable devices, using wearables and mobile applications in the Internet of Things. We can see that every day there is a new device, a new application, new wearable device that has been generated to collect more information about the patient. Different stages of their lives, and we can see everything is becoming smart. Starting from the rings, the glasses, the shirts, the watches, the belt. Everything is becoming more smart and connected to the internet, and this creates the ecosystem where you have the different devices, systems collecting more information about you to help. And what we're trying to do is that maybe it's a good idea to use a blockchain where we can actually connect that data together in order to make sense of it, regardless of the usage of it. And that will cope with the modernization of our modern society, where we use applications, smartphones, to collect more information about us to help us. Another use case, a third use case, is to use it in big data analytics. And I'm working with the MIT team on a system called OPAL, which is Open Algorithm. And the idea of OPAL is actually to help share answers, but not share the data. So there is a movement. This patient-centered care is all about, sharing more information, painting the full picture and all. But still, the systems are not ready. So one example here is to help people ask questions about the data that I have, and I provide answers. So there is a querier who can actually ask questions to the data owner, and those questions are translated into algorithms and queries, and there's a machine learning that happening from multiple people, multiple systems. Data owners could be one person, could be multiple people, and these questions are actually asked across different systems, and then an answer will be generated. So not the data, it's only the answer, and it's a safe answer because it gives exactly what we need to do. And the blockchain here is about tracking the question, the querier, and the answers generated as part of that OPAL system. So this is to be used in big data analytics. A fourth use case is with organs and the donors registry. It's very important to be accurate, transparent, and make sure that is actually tamper-proof, to give people the priority based on the transplant list that is available, and to save lives. So this is very, very important to be. This is one way that you can track those lists using blockchain technology. The last use case is in pharmaceutical and drug and trials where they actually test out drugs on patients. So there are different stages there where they actually have the first round, second round, and get to monitor what that drug is actually having effect on those patients. I think blockchain is very useful here because it gives you that time frame or time stamps of the different sequences for the different stages of the drug undertaken, and then you can help analyze that and make decisions about the drug and how to improve it. So those are my use cases, and I hope that was useful. Thank you very much for having me.
Okay, Shada, thank you so much for the presentation and all the use cases. And students, I hope you enjoy all of Shada's insights. And I'm sure we're going to have some more questions for you. And thank you again.
No worries. Thank you very much for having me. Goodbye.